Do a welcome to you all. Thank you very much for coming to join us today. My name's Liz Jones. I'm the Policy Director at the National Care Forum, and we're a member of the Care Provider Alliance. And we're running 3 webinars over the next this week and the next 2 weeks, looking in more depth at the liberty protection safeguards. So this week's session is going to focus on home care. Next week's session will focus on care homes, and the third week will focus on supported living and extra care. So a little bit of housekeeping, if I may. It would be really helpful to our presenter, Rachel, if you were able to pop your name, organisation and role in the chat. You'll see the chat function along the bottom. And we also have a Q&A function in the webinar. The reason for that is that we will endeavour to answer your questions today, but if we don't have time, or if some of them are a bit more complicated, we're planning on producing a full Q&A document at the end of all 3 sessions. So a kind of jumbo Q&A document. So let me introduce our LPS guru. We're delighted that we've got Rachel Griffiths with us, who is an expert in all things mental capacity and human rights. And she has kindly offered to walk us through in each webinar what the liberty protection safeguards mean. So this session is focused on home care, and I'm going to now go on to mute and switch my camera off and leave you in the capable hands of Rachel. Oh, and the webinar is being recorded so that we can share it for people who haven't been able to come along today. I think by continuing to stay with us, that means you're consenting. So over to you, Rachel. Thank you very much.
Hi, thanks very much, Liz. Hello, everybody. Thank you very much indeed for joining. Could I have the next slide, please? This is what we're going to look at today. So I think a lot of you have joined because you've been hearing about LPS for a bit, Liberty Protection Safeguards, and I think we all get a bit alarmed about things when we don't know a lot about them. I've got a bit of a spoiler here in that there are things about it that nobody knows. There are bound to be things about it that I maybe should know and don't, though I've been very involved in all the implementation of it. But anything I can't answer today, I will certainly answer of your questions when we've done these 3, and you will get a list of Q&A, some of which will say, we don't know that yet. So we're going to look at what is going to happen and when, and what will it mean for you, for your services? What can we do now? And some resources and reasons not to panic. Next slide, please. So in very brief, we are going to change from something called DOLS, Deprivation of Liberty Safeguards, which didn't concern you directly, to Liberty Protection Safeguards, which will. Next slide, please. Now, remember that this doesn't apply to everybody, and I think this is particularly true for your service area, because I think you often work with people who do have the mental capacity to make their own decisions and consent to what is going on. But remember that you should be working with the Mental Capacity Act anyway if you provide any services to people who are 16 or over and lack mental capacity. Remember that capacity is not global. You shouldn't say somebody lacks capacity without saying for what decision. So it's always decision and time specific. Somebody may have capacity to make their own decisions about what they eat and drink, but maybe not about some of their personal care because they don't think they need it, or their medication, which they forget about. LPS will only apply when somebody can't consent to what LPS calls the arrangements. But I think if we think of it as a care plan, we won't go far wrong. And that care plan has to be essentials that the person really does need, and that it amounts to a deprivation of liberty. Now that's the first kind of scary technical bit. Next slide, please. So what is deprivation of liberty? You may have heard of this thing called the acid test. Somebody is deprived of their liberty if they lack mental capacity to consent to what you're doing, and if they are under complete and effective supervision and control and not free to leave. Now, the law says, the courts have said, we should err on the side of caution in thinking about this, because it's not going to be up to you to make all the big decisions about deprivation of liberty. All you need to be able to do is to know when to ask somebody else. Usually for you, it's going to be your local authority team to have a look at it properly. And remember Lady Hale's phrase, a gilded cage is still a cage, even if it's lovely care, the best that that person could have. If it still means they're deprived of their liberty, we need to take care that their human rights are protected. Next slide, please. The difference between restraint and deprivation of liberty. We're not going to have time today to do a full Mental Capacity Act run through, but you need to notice when you are restraining somebody in terms of the Mental Capacity Act, because that locked front door, if there is one that the person doesn't have the key to, if you see the second bullet point, that is a well, it's not a deprivation of liberty, sorry, that is a restraint. So there are usually lots of restraints when a person is deprived of their liberty, but for any restraint, you should get in the habit of always thinking there is a restraint here because there's a locked front door. Is it necessary to prevent harm to this person and a proportionate response to the harm that the person would come to if they ran out into the road or went out and got lost looking for where their mum lived 80 years ago and then couldn't find their way home, or whatever it might be for that individual. And there's more of that in the current code of practice, and there will be, of course, in the new one. Next slide, please. So what the LPS is doing, it's providing protections. And I think we need to remember that that's what it's about, really. It's not about restraining somebody and depriving them of their liberty. It's about recognizing when they need to be deprived of their liberty because there isn't a less restrictive option and because it is the right thing to do for that person. And LPS, liberty protection safeguards, give the person the same rights that DOLS has given some people already. Next slide, please. So what's new? Lots of people were missing out on DOLS protections because they only apply in care homes and hospitals. They only apply from people's age 18 and upwards. LPS has come in line with the rest of the Mental Capacity Act, makes it easier to think about it as part of the Mental Capacity Act, which it is, that it applies from 16. And anywhere where that person is, might be a day centre even, but certainly people's own homes are coming into this for the first time. So you see now why you're here. Next slide, please. Now, the entire plan of this is for it to be simpler than DOLS. I think at the moment it's not looking a huge amount simpler, but I think it's up to all of us to remind government and those running the system that their intention is that it wouldn't be as jargony, wouldn't be as bureaucratic, wouldn't have rigid forms, would be much more flexible and intuitive. And of course, the government wants it to be cheaper. You know, I think there are things that need money to be spent on them in health and social care. And while this is one of them, we don't want it to cost more than it has to. It's easier to extend it if somebody's situation is very stable, don't have to keep rushing about. And it can cover some different settings or transport between those settings, as long as that's been planned. So it's kind of more global in a way and simpler. Next slide, please. So what is it going to mean? I'm just running through what it means for the others as well as for you, just so that you see where you fit in. Now, care homes for the elderly have been working with dolls. It's not going to be much different for them. Probably will be a bit simpler, but it's going to be very similar to what they are doing anyway. But it is new for anybody providing supported living services, shared lives, services for 16 and 17-year-olds. That's even children's secure homes, other settings for children. Now, currently, if in somebody's own home, for example, you're depriving somebody of their liberty. Well, if you're in your own home, you can't use dolls, and if they're under 16, you can't use the Mental Capacity Act, but you can apply to the Court of Protection, but you wouldn't do it. It would be the local authority and the commissioners. And that is going to be the same, really, with LPS, but there is going to be a new process and new systems and some new words to get used to. You won't have to do any of the assessments or the decision-making called determinations, and you won't have to give authorizations. Next slide, please. So you should already know about deprivation of liberty. You may have come across people deprived of their liberty, but it's not going to have been much to do with you. And the reason why I said you need to know about restraint and what deprivation of liberty is, you need to know also where to find out more information, which we're going to be telling you here. And you need to know about how the process is going to work a bit. Now, there's going to be a massive amount of publicly available information about how it works, but now is not the time for that. So again, it's not going to be your problem to do the technical and the bureaucratic bits of this. Next slide, please. It's important to remember whenever we start getting alarmed by this being new, which it will be a bit, why we're doing it. And the vital purpose is to protect the human rights of people who are quite intensely restricted and who lack capacity and maybe are not very good at sticking up for themselves because they're confused and they don't understand the system. It also does protect staff because it makes it lawful for you to be doing what you're doing. Next slide, please. Right, I don't want you all to switch off, but we're not going to get this for at least maybe 18 months and maybe even longer. We don't have a date yet. The timetable allows for at least 6 months of training, which is going to start after next winter. And the training is going to be free and there's going to be quite a lot available. Next slide, please. So this is the government's timeline. So you can see where we're in at the moment. We're in the public consultation on LPS, which I'm going to say a bit about in a moment. Spring through to summer. That closes on July the 7th. Then the government is going to be considering all the consultation responses that we're going to flood them with. And that's good. I'm glad they're going to do that. But then we're through to next winter. Then they're going to publish what will turn into a proper code of practice for how to work within LPS. And then in where it says next stages, that's when There's going to be loads of training and a launch date at some time. I mean, things feel a bit politically turbulent, so I really don't know, but it can't happen before autumn 23. Next slide, please. And we did want to tell you about the public consultation. If you look on the link that you get at the end of this presentation, you will see that there are a great number of documents. The summary is very good, I'll tell you that much. When I say we are planning a full response, that's the 4 organisations that have worked together to produce these 3 presentations for you. So that's Care England, ARC, RNHA, and Liz's organisation, National Care Forum. But I'm sure that any organisations that you're dealing with might be doing responses, but please put in your own. It's very good to tell them what you think. Really, I think the ship has sailed for us having a totally different system, though you could tell them if you wanted that, but really more about what's going to work in practice and what do you understand. Next slide, please. Now, the government training triangle is quite handy for us at this point. You will see that the higher up it goes and the more weird bits of jargon we get, the fewer people need it. So it ends up at the very top with an AMCP, that's an approved mental capacity professional. The only bits that are going to concern you, however, are level A at the bottom, awareness raising, which is what we're doing now, and B, identification and referral. We're learning a bit about identification now. You won't learn who to refer to until we've got the bodies in place for you to be able to recognise. But for you, they'll be in your local authority almost certainly. So awareness raising, it's the context of the Mental Capacity Act, which is why I've already talked a bit about that. So we will carry on with that. But that training triangle is to give you confidence that C and above is going to be specialist roles, which you'll come across, but you won't be it. Next slide, please. So responsible bodies, I don't know how many of you are in Wales, but I've put in brackets what will happen in Wales. Quite honestly, it's simpler in Wales because not as much is changing for Wales as it is changing for England. But we're going to have these things called responsible bodies. The responsible body is a hospital manager if it's an NHS hospital. In Wales, it's still going to be your health board. Clinical commissioning group, which vanishes any day now, so it'll be the integrated care board. If, and this is the only one that might affect some of you, if the person's funding is NHS continuing healthcare. But in Wales, it's still going to be the health board. And for everybody else, it's the local authority. So all care homes, community settings, people in their own homes, and also in England for independent hospitals, but in Wales, you got it, it's the health boards. So Wales, you're ahead of the curve on this one. Next slide, please. And there are 3 assessments. A capacity assessment. I'm sorry about the capital initials in here, it's to keep the slide shorter. Social workers, occupational therapists, psychologists, nurse or speech and language therapists, those are all registered professionals, or I should have put in there a doctor. A doctor can do that, any registered doctor. There's an assessment of do they have a mental disorder, that has to be done by a doctor or a clinical psychologist. And then the final one, which is at the heart of the whole thing, is this, just like any restraint, is it necessary to prevent harm to this person and proportionate to what would happen to them if we didn't? And you will hear that called N and P, which confused me the first time I heard it, but it's just necessary and proportionate. So that's really what LPS is all about. And that's a phrase I would like you all to take forward from today. Next slide, please. So how do LPS protect the person's rights? It's by helping us all to notice when somebody is or might be deprived of their liberty. And then this responsible body I've spoken about will arrange the checks on whether they do lack capacity, do have a mental disorder, and whether it's necessary and proportionate, and gives the person a right to challenge. That's all somebody acting on their behalf. Next slide, please. So what do you need to do to be ready for LPS? Admittedly, because it's a long way down the track. It really is to recognise that this is part of the Mental Capacity Act. Make sure that I've given you the 5 principles of the Mental Capacity Act here. They are so important. And I guess LPS comes in at numbers 4 and 5. Depriving somebody of their liberty must be in their best interests, not just for organisational convenience. And you should be unable to find a less restrictive option. So always look for a less restrictive option. Next slide, please. Next thing you can do to get ready is make sure that all the people that are working with you have the confidence not to be frightened of the Mental Capacity Act. The Mental Capacity Act is a very intuitive act. It was designed to reflect existing best practice. And you might be sitting there thinking, well, she would say that, wouldn't she? But I promise you it is true. But always ask yourself about any restriction, that locked front door, is it necessary and proportionate, and record why. If you think it might be a deprivation of liberty, discuss already with your commissioners or your local authority DOLS teams if you're worried, because already somebody, and it wouldn't be you, somebody should be referring this to the Court of Protection to get authorization if they are deprived of their liberty, remembering they lack capacity as well. Start collecting assessments of mental capacity and mental disorder. For one thing, it helps you to know the person better and to understand how you can support them in a more free way. And when we come to LPS, you'll be so popular because the local authority or whoever else, maybe the Integrated Care Board, won't have to go scrabbling about looking for assessments. And when the time comes, do look out for and join any local implementation groups. There should be some. I can't promise there will, but that's the current plan. And that will help you know who in your vicinity are the people that you would refer to. And once you actually know them, it's so much easier then to ring them up with, you know, this may be a stupid question, but I'd like to talk through if we might be depriving so-and-so of their liberty as part of their care plan. And if so, what are you, oh local authority, thinking you might do about it? Next slide, please. And these are some resources. The public consultation, remember there are loads of documents, but you'll cope, and they don't want very long answers. They've got very many problems with their spelling and pronunciation, their spelling and their grammar, and the things links not working and that kind of thing. For those, you ought to let them know at the where the government fact sheets are. You will find an email address for the LPS team rather than put it in the public consultation. But if you can't find anywhere else to put it, tell them there. So there's fact sheets already and they're going to update them. There's the latest news, which we're all looking out for really. And Wales is having some extra consultation. So lucky people in Wales, you get to have 2 lots of consultation, but at least you're going to be heard twice. Next slide, please. And remember, when you get confused about all this, that it is like the dolls, that the person is at the heart of it, but then liberty, protection, safeguards. If you get confused, think about the Mental Capacity Act principles. If you get confused there, just think about people's basic human rights, like the right to liberty, as long as it's safe for you to have as much liberty as possible. So that's been a huge whistle stop. I know questions have come in, and I know a lot of comments have come in on the chat. I'm going to be very dependent on Liz to tell me what's going on there, because I'm a bit of a one-trick pony and I can't do 2 things at once. So I ignored all your questions. But now I would very much like to answer those that I can, bearing in mind that has been a really quick canter through the whole thing.
You've got one more slide, Rachel. You've got a don't panic slide.
Oh,
don't panic.
That's the big one. I won't panic. I won't panic. I was so pleased with the drawing. I mean, the picture, you know, not a drawing, that what I'm modeling here, everybody, is that you don't have to be perfect. You can do your best and you will get there in the end. Yeah, I do remember that what it's supposed to be is such a good thing that I want you all to welcome it and enjoy the fact that you're part of a system that's going to protect people who really need protection. And then we're on to the Q&A. I haven't missed another one, have I, Liz?
No, we're good. So thank you, Rachel. We've got a few questions come into the Q&A, and because I didn't realise I can't put answers in, I've inadvertently answered one with my question. So let's take it from the top. Oh, so just for all participants, we are recording the webinar and we'll share the recording and the slides. I think we'll probably put them on the Care Provider Alliance website. I'm not entirely sure how we'll share them, but we will be able to share copies of both things, because I'm sure people would probably value these in terms of using them potentially within their own organisations. So we had a question from Sarah at Surrey Choices, who said, I'm interested to find out how this impacts on day services as well.
Aha, brilliant question. If it is planned that a person who's receiving care in their own home is going to go to a day service, or if they're going to have respite care, say once every month or however often, provided it's known about and it's built into the care plan, a great advantage with LPS is that it can all be covered. I think that the key to that is knowing what the plan is. So if you've got a care plan that Mrs. A goes to a day centre every Thursday and once a month she has a couple of days respite to give respite to her family who are also providing some of the care, as long as it's covered, all those settings can be looked at. And if she's likely to be deprived of her liberty in all of them, it would cover that. And it would also maybe say she's not deprived of her liberty in the daycare because she has more freedom there. I can't quite see how that's going to work. I'm thinking on my feet. But the crucial thing is it's very person-centered and very centered on what those plans are for that individual. So that's a very good thing about it, and I'm very glad you asked that.
Excellent, thank you. There's a question from me, and it was prompted by you talking about what might already have been in place in terms of visibility to operators of home care services. And I realised I didn't know the answer to this question. Who would be telling people now that somebody that somebody potentially needs to have some sort of protection around their liberty, and who will tell them in the world of LPS? Because think about your court of protection reference. And then I was thinking, okay, what does that actually look like
Yeah.
in the new world of LPS for somebody who goes in, you know, every day for 2 hours a day or an hour a day or whatever?
Yeah, that is a brilliant question. Again, the way LPS has been designed, the intention is that all of us and any of us have a kind of duty, if only as citizens, but certainly because we're providing services, to make it known to the responsible body if we think somebody might be deprived of their liberty and it's not been recognised. People providing care to somebody in their own home often get to know that person so much better than the commissioner of the service, if that's the local authority, where staff have leapt in, done a care plan and leapt back out again. You may well be the people that spot first, particularly in somebody's own home, if they might be being deprived of their liberty. It is also relevant, and I didn't go into this, maybe I should have, that people in their own home, the bar is higher for them not being deprived of their liberty. I don't know if the not is in the right place there. What I mean is, if you are at home, it's a familiar setting, familiar people around you, often familiar people in your family members providing at least some of the care that you need, and you're living somewhere where you've chosen to live very often, and certainly where you've been happy to live. So it is less likely, the government is certainly suggesting at the moment, that you would be deprived of your liberty. But there are some elements of what a deprivation of liberty will consist of under LPS, which is still being fought out. And some of the examples in the draft code of practice are making the lawyers get very unhappy, and some other people. I mean, I'm not sure about some of their examples. They seem to be bringing LPS in, but then saying it's not a deprivation of liberty if you ever spend any time on your own without carers there. And I think at this stage, don't rely on the draft code because it's not law yet. It's not a statutory code, which it will be. But also, if you are in doubt, you don't have to pay anything to ask, and particularly when LPS start, we'll all be feeling our way. Contact your responsible body if you're in any doubt. And if they say, yes, it is a deprivation, or no, it isn't, look at why they're saying it, and then you can help learn for other people. But it does no harm to ask. And for people in their own home, you are maybe very much on the front line here of recognizing that there might be a problem.
That's really helpful. So I think that works both ways, doesn't it? From kind of seeing that that person actually might be being deprived of their liberty because of the best intentions of their relatives, for example, but also considering whether you're seeing a risk as well.
Yes, and again, remember that to get authorised, whether under DOLS or by the Court of Protection now or in the future by LPS, it has to be good care. We are not in the business, and never will be, of authorising rotten care. But now, if you saw bad care, if you saw a son using his mother's money, pension money, to get drunk and was beating her up, or you thought he might be, you know now to contact your local safeguarding team. And that stays the same. This isn't about authorising bad care. It's not about authorising things that you wouldn't want to happen to yourself or to somebody that you loved. It's about the protections. If you know that mum, if she goes out, will start looking for where her mum used to live, you want to keep her safe. You may have various things. You may have pendant alarm or door sensors, or you may have locked front door or locked gates. It's looking at the minimum necessary, that's necessary and proportionate to keep her safe. And paid staff benefit hugely from the fact that they're then protected from liability. But if in doubt, shout, I guess.
Yeah, that's a good line. If in doubt, shout.
Yeah, make it up.
So we have a question from Sonia. Sonia says, sorry if I'm jumping the gun. Where we have staff who provide a lot of care and family who provide some of the care, if the acid test is met, does it matter who provides the care for the authorization to be required?
Brilliant question, Sonia. And the answer is, it truly doesn't matter who is providing the care. If it's not, say, your staff who are depriving the person of their liberty at all, it's still part of the care plan. And there's a concept in deprivation of liberty law about whether the state is involved. By the state, you have to include anybody providing a service, say, who's registered with CQC. That means you are an agent of the state. You don't feel like one and you don't act like one, but for this purpose, you are. And anybody who's got a GP, the GP is also an agent of the state. So as soon as you know, you then do have a duty, which LPS is going to help you and make it easier for you to notify the right people, because it'll always be your local authority responsible body. And they will come in and bottom out the situation. And so it doesn't matter who's providing the care, but you may be the ones that notify the local authority. You may also, if you would be so kind, be the people who explain to the family, who sometimes get jolly annoyed at the idea we would never deprive him of his liberty. Of course we wouldn't. That, of course they wouldn't, but in legal terms they might be, and it's about simply about protecting his rights. And so you look at protection of liberty, safeguards, the title means what it is. It's a lot easier to justify than deprivation of liberty safeguards, I can tell you, where the title put most people's backs up.
So I think we've got two things there. If in doubt, shout. And when they come into being, understand, as you said, who your responsible body is, who is going to be dealing with this at the local authority, and make friends with them.
Yeah, so it'll be at the local authority almost always, but if the person is receiving NHS continuing healthcare, CHC, then it's going to be the Integrated Care Board. And just to make things easier for you, it doesn't exist yet, but when it does, it's going to have this responsibility when LPS comes out. It's currently the Clinical Commissioning Group, CCG. But they'll never have to do it.
I've got one more question in the Q&A, and then I've got a hand from Clive. Clive, do you want to come in after that, or shall I do the other Q&A one?
I don't mind, Liz. I can do it now if you like.
Okay, do you want to do it now?
Rachel, thanks very much again for the talking us through this and helping sort of demystify some of it. Obviously, LPS will increase the number of settings and the number of people that potentially would otherwise not have come under the old DOLS system. Do you know anything about the way that authorities and responsible bodies will be resourced to respond to that? Because we had some catastrophic waiting lists and challenges that put providers in quite a difficult position where they know that they've got DOLS that haven't been approved and all the rest of it. And I just wondered if you could comment on where you think we are in terms of resource.
Certainly. Where we are with LPS is that we are now on to the third or possibly the fourth version of the government's impact assessment. It's also there in the huge numbers of documents that I mentioned that I've given you a link to. The government knows it's got to fund this quite how it's is being fought very merrily by local authorities and by the local government association and by lots of other bodies. Yes, there is going to be a widening of who's involved. However, the costs of going to the Court of Protection are very high, and those costs will still happen occasionally when there's a really difficult situation and, say, family are completely at war with the commissioners of a service. Sometimes it would have to go to the court to get a decision, but in the main, things won't go to court. Some of the stuff that caused delays in DOLS, like the complexity of assessment, is being minimised, that you're not going to have such specialist assessors. They're still specialists, they're registered professionals, but they're going to be doing a lot of these assessments while they're doing, say if they're doing the Care Act assessment, the idea is they'll bunk these assessments in, as it were, along with those. So their costs are, I mean, the government acknowledges there are going to be costs. It's cheaper than keeping going with DOLS, certainly if DOLS got properly resourced. So they are aware that they need to do this to protect people's rights, and the costs are going to be met. Costs to care providers are less sort of immediate. There are training needs for sure, and the more you can make sure that you're keeping up with Mental Capacity Act training, the more you're not going to have to take a lot of time adding in LPS, because once you really get the Mental Capacity Act under your belt, LPS actually will fit in fairly well. Government is definitely providing a lot of free training through Skills for Care and Sky and Health Education England. So there's going to be a lot of training and learning materials, and the responsible bodies will have a no wrong front door principle. So if you approach the wrong one, they will, in a kindly way, put you right. And I'm hoping that they will help. So yes, there are costs to the system. Not so much, I don't think, for care providers, a training cost, which we are working very hard on getting government to recognise fully. I think they're underestimating it myself in their impact assessment, but I'm onto that in a sense, at least shouting about it. So I hope that's answered your question a bit, Clive.
It has, thank you. Thanks, Rachel.
Thank you, Rachel. And I guess this probably links to the final question we've got in the Q&A. Can you just clarify again who will be able to carry out the assessment? Is it restricted to registered professionals?
Again, a really excellent question. For LPS purposes, yes. For general purposes within the Mental Capacity Act, we should all be able to carry out a capacity assessment. If it's a really tricky one and the person has got a complicated, fluctuating mental disorder, you might need help. But everybody should be confident about a basic capacity assessment, or basically thinking about how to decide what's in somebody's best interests. But for the LPS, because it is a legal framework, it's going to be the registered professionals. I whipped through them, but for capacity assessment and for the capacity assessment can be a doctor or a psychologist or a speech and language therapist or a social worker or a nurse or an occupational therapist, but they have to be registered professionals. And again, for doing the mental disorder assessment, that has to be a doctor or a psychologist, and the group of professionals like the nurses and OTs and so forth, they're also the people who do the necessary and proportionate. There is this extra role called an approved mental capacity professional, who will only come in either if the person is very unhappy about their care plan. If somebody is really objecting, they lack capacity, but they're trying to climb out the window all the time. That's the main example of when an approved mental capacity assessor would come in. And the rule with all the assessors is they've not got to have a conflict of interest. So they've not got to work in the team that is depriving the person of their liberty. They've not got to own an independent hospital or a care home and be providing assessments into it. It's the kind of stuff you would expect, somebody who's not in the line management. So that is laid out in the regulations, and I don't think it's going to change very much. So again, you would get a social worker being involved, or somebody of that, if I say of that type, you know what I mean.
Yeah, yeah. And I think it might just be worth also saying a bit, Rachel, about the efforts in this new system to really put the person at the heart of it and make sure that they've got the support they need for expressing their views where they can.
Certainly.
I can't remember what the new role's called, or the revised role, the best interest role.
Well, the approved mental capacity professional is replacing the BIA, but the person doing the necessary and proportionate has to consult and find out what the person wants. It might seem a simple, deceptively simple question, but sometimes there has been an assumption among commissioners, such as like, well, nobody wants to go into a care home, so the fact that they don't want to go, we're going to effectively ignore that. The problem with finding out what the person wants, I mean, it's very important, but it's what are the available options for this person? And at a time when resources are being stretched more and more and more, it may be that if this person was a member of the royal family, you would certainly keep them at home and have teams of carers going in, but that the local authority commissioners for this individual will not pay for more than a certain number of visits. And so the person maybe is subject to more restrictions anyway, in terms of locked doors when a carer is not there. And that gets a lot harder for people to work out, but we can't force the government or the local authority to do more than they are able to do. And so it's the person is at the heart of the system, and their wishes really do matter. And if they are objecting in any way, which may not be verbal, it may be trying to climb out of the window, or it might be shouting and saying that they are being kept prisoner. I knew a lady who said she was being kept prisoner by the Queen in one of her castles. I bet she's convinced she is after the past 4 days, but still. Then the person would see the approved mental capacity professional, who really is an expert in minimizing restraint and helping to understand. I think it's a step forward that they've brought speech and language therapists into this, because they are people, some people have got communication difficulties that you need the expertise of that kind of training. So I think it's a step forward.
And just thinking about people who may not have family or friends who can support them in terms of their advocacy.
Thank you very much, Liz. Yeah, we've already got people called independent mental capacity advocates, IMCAs. It's terrible how everything gets shortened. but you can see why. The IMCA service is involved in DOLS at the moment and is involved when people who lack mental capacity are facing major decisions. So it's about where to live or serious medical treatment, and they have nobody in their family or friends who can be consulted, who will know what's important to them, what they would want if they'd got capacity. And so the IMCA service is going to be expanded quite a lot, that if a person has nobody, they'll have an IMCA from the very start of the process, right through the whole length of their authorisation. Now, Clive asked about funding the increase in IMCA support, which the local authorities have to pay for IMCAs and resource them. And they are already worried both about the cost of increasing it and making sure the government will pay for that. They have put money aside for it. Who knows if it's quite enough, but they're finding it very difficult even to recruit more people to train as IMCAs. So I think we've got some glitches along the way, but it is the person-centeredness is what I think we all need to promote. And if somebody has nobody, certainly let your local authority know if you think they are being restrained and they have no family or friend to speak up for them, that they might do with an IMCA, independent mental capacity advocate. So I think that is a very good thing to be reminded of. Thank you, Liz.
Well, thank you, Rachel. I think we're probably at the end of our Q&A. I can't see any more in the Q&A and I can't see any more in the chat. And I think I was just reflecting on Clive's question, and I think you're going to be doing a bit of work with the people who are trying to prepare the responsible bodies, so with local authorities and possibly the NHS folks.
Yes,
you're going to be supporting them so that we can feel confident that you will take the perspective of the care provider into those discussions.
Actually, I always do, because I have worked in care settings. I know how crucially essential and brilliant the work being done is, and I know how you can sometimes feel forgotten about. And I do shout up, and also I know that Liz has been involved in this and has also shouted up, as have all the organisations I think that are represented here. We're all doing our best, but have a look at the consultation document, and if you get half an hour with a cup of coffee, have a go at telling them what you think about things.
Brilliant. Because I think that's a great message. Thank you. I think that's really important. If you can get a chance to have a look at the consultation, tell them what you think, not just necessarily answer the questions. I'm loving the don't panic message. It's simple, it's flexible, it's more intuitive, and it offers protection. And your other point, if in doubt, shout. That's going to be my new mantra on LPS, Rachel.
You've never held back, Liz, as far as I could judge. But,
what do you mean? What do you mean? Oh dear.
But it's not starting for ages yet. But honestly, it's worth getting ready by brushing up on the wider Mental Capacity Act. Really, it is.
Brilliant. And there's some great resources on the Sky website, by the way, folks, if you do want to have a look.
Well, yes.
Really good. Okay, well, unless anyone's got any other questions, I'll give you 5 minutes back. Thank you, everybody, for coming along. Thank you, Rachel, for being our guru. Thank you, other panelists, for helping, keeping an eye on the chat. And we'll see some of you next week. Well, we'll see another chunk of you next week. And
I'd just like to thank you all for being so involved and so much part of this. It's difficult when it's online. But thank you so much, and they were brilliant questions. So thank you.